This program is brought to you by Emory University.
Good morning, everybody. Welcome to the last Friday morning conference of 2020. We're ending on a high note with Dr. John Ricketts talking to us today. John is a third-year fellow in our clinical track. He is a native Alabamian. And I guess I should stop at this point and welcome his father, Dr. Ricketts Sr., who's joining us today, who's I hope I'm getting this right, but if I recall, he's an internist in Alabama in, was it Montgomery, John?
Montgomery, Birmingham, kind of all over the years.
Got it. Okay. Well, welcome, Dr. Ricketts Sr. John, again, as I mentioned, native Alabama, University of Alabama, undergrad, University of South Alabama, if I recall, for medical school, Emory for residency. Did a chief resident year at the VA with the Morehouse program, and then joined our program a few years ago. And he is going to talk to us today. He's been doing an imaging block for the first half of the year, learning advanced echo and CT in our echo lab and with our structural team. And he's going to talk to us today about cardiac cartography, which I assume is about cardiac imaging. Yes, multimodality map making. Dr. John Ricketts.
All right. Thanks, Dr. Williams. I've given a lot of talks over the year, both in residency, chief residency, and fellowship. And I've long said that the key to a great talk is coming up with the perfect title and then just building your entire talk around that. So I may be peaking here at the end with cardiac cartography, multiple modality map making in modern medicine. Financial disclosures, I have none. So our learning objectives for today, I want to define the discipline of multimodality imaging within the field of cardiology. We're going to discuss the role of multimodality imaging in fellowship training, but we're going to spend the vast majority of the talk today really exploring different imaging modalities and how they can assist in the diagnosis and treatment of some complex heart conditions. So let's orient ourselves real quick. This is what is known as the Imago Mundi, or the Babylonian map of the world. It is a clay tablet containing an early map of Mesopotamia, dated to roughly the 6th century BC. So you history buffs will recognize that as the Neo-Babylonian or early Achaemenid period, so sort of right after Cyrus the Great conquers Babylon. And what this map shows is it's got this line down the middle, which represents the Euphrates, this line going through it that represents Babylon, kind of straddling the Euphrates, and sort of different cities from around the area, places very famous like Susa, Elam, Urartu, Assyria. And this today is considered the oldest surviving map in the world, discovered in the 1880s, about 60 miles north of Babylon, around modern day Baghdad. All right, so part one, let's talk about multimodality imaging. So early development. Inga Elder and Helmut Hertz first described the use of M-mode echocardiography to evaluate mitral stenosis and mitral regurgitation in 1953. These were the images that they obtained. They're a little bit grainy and not as high quality as we get these days, but I'm sure anybody who's ever looked at a full series transthoracic echocardiogram will recognize a lot of these kind of patterns and waveforms that we see here, including the opening and closing of the mitral valve within the left ventricle right there. The first CAT scan was done on October 1st, 1971 at Atkinson Morley's Hospital in London on a patient with a suspected frontal lobe brain tumor. And this is the scan that they obtained. Now, they used a combination of X-ray and early computer technology by Godfrey Hounsfeld, he of the Hounsfeld unit at the EMI Central Research Laboratories in London. And this scan that they obtained produced an image with an 80 by 80 pixel matrix. Took about 5 minutes for each scan. To give you some frame of reference, our modern scanners today produce a 1024 by 1024 matrix in about 1/3 of a second. And so we made a lot of progress over the years. We developed a variety of imaging modalities and really fleshed them out. Things like transthoracic echo, transesophageal echo, cardiac CT, cardiac MR, nuclear cardiology, things like SPECT and PET. And this is a schema that I developed for one of the imaging talks that I give to the residents, which really kind of breaks down the full breadth and depth of this sort of imaging that we can provide for the heart. I divided into radiation and non-radiation. We're going to talk a little bit more about radiation later on in the talk today, but you've got everything from fluoro to nuclear to CT to ECGs. So remember, just because we're not taking a physical picture of the heart doesn't mean we're not imaging the heart. So here we're just imaging the electrical system, to ultrasound, which probably provides us with our most variety in different ways that we can obtain images, to MRI, which a lot of people consider the gold standard and really is the gold standard for a lot of the different kinds of imaging that we obtain. So what's multimodality imaging? So multimodality imaging, or MMI, uses a patient-centered approach to select the best available imaging test when evaluating patients with unknown or suspected cardiovascular disease. It may require integrating information from various different modalities to answer the clinical question at hand. And there's a subset of that known as hybrid imaging, which is where we use information from different modalities and combine them and either visualize or analyze them together either during or after acquisition, and can be helpful in evaluating certain cardiovascular disease processes. There is no one perfect imaging modality. I cannot stress that enough. Even cardiac MR, which we consider the gold standard for a lot of things, is not perfect. Every single one of these modalities has trade-offs. That could be trade-off of image quality. How invasive is the procedure? What are our patient limitations? So patient size, everybody's dealt with that before. Claustrophobia, renal function, all the things that I'm sure many of you have talked about when trying to figure out which test you're going to order for a patient. There is radiation. We see that word popping up again, and I hate to defer, but we will talk about this a little bit more soon in the talk. But also, what are we trying to visualize? Are we trying to look at the structure of the heart? Are we trying to look at blood flow through the heart? By looking at perfusion, so which part of the hearts are getting blood, or am I looking at function, be that of chambers, valves, what have you? And multimodality imaging is all about learning how to balance those trade-offs to maximize the benefit for your patient while minimizing their risks. So this was a helpful diagram from one paper that was published in Heart earlier this year, talking about multimodality cardiovascular imaging, just to give you an idea of kind of the main domains that we usually think of. So of course, echocardiography, transesophageal and transthoracic, cardiac CT, nuclear, so that's PET and SPECT, as well as cardiac MR. In my talk today, we're going to really focus on this group over here, which is what I've spent most of my time studying in my training. Little bit of nuclear, little bit more CT, a lot of echo. So historically, advanced imaging training is focused on a single modality, which leads to unbalanced expertise in development of what they call silos in imaging. So I'm sure, every attending and trainee here, will recognize that as you're going through your training, we really don't have multimodality imaging months, right? You're on echo, or you're on nuclear, or you're on vascular. Maybe you take a couple of months later on to do a little bit of MRI. Now with our new structural rotation, you'll get a little bit of CT. But unless you're really taking the time, like me and some of my colleagues have done, to design a multimodality imaging block, you're not using a lot of these modalities together at the same time. So the training and subsequent practice of multimodality imaging should really cross most, if not all, avenues of cardiac imaging in order to really understand which modality or modalities are best suited to answer each clinical question and to guide each individual patient's care. So this was a great position piece put out a few years ago by the editors at Jack Imaging that really talked about what is multimodality imaging, what should it look like, and how do we get it to where we want it to go. And they had some interesting quotes in this position piece, and I thought that these were two important ones. So one, multimodality imaging comes at a time when there are many divergent forces buffeting imaging. So first is the fragmentation of imaging expertise into narrow modality-specific areas. Sort of as a side piece, Dr. Gleason and I were talking, I think last week or the week before, and he was talking about somebody that he knew that was at a hospital and was designated as the head of left atrial appendage occlusion CT imaging. And you want to talk about a really narrow specific area. That's the kind of thing that we're trying to avoid. And so each of our four major modalities, echo, nuclear, CT, and CMR, was developed independently, and we continue to think about them as individual silos partly because they're frequently not co-located at training institutions, right? So you may have your echo lab where your transthoracics and TEEs are done. We may have, you know, a radiology suite where our CTs are done and then they're read in a different area. We've got our MRI in one wing and then our MRI reading room in a different area, and nuclear sort of in its own area. And you know, a lot of different hospitals, you may have radiology running CT and MRI, and you know, maybe nuclear medicine running your nuke department. I think luckily we kind of have a stranglehold on echo because nobody else wants to read those. But it's really important to think that, you know, at different institutions, these areas can be really separated out, not just geographically, but among different specialties within imaging. And they say, we as the editors of IJAC or JAC Imaging feel that imaging modalities, despite originating individually, should no longer be seen as silos. And this emphasis is my own, but cardiovascular imaging is fundamentally about the information in the image, not how it is acquired. And that is the real strength of the multimodality imager as a subspecialty within cardiology, is knowing enough about the different types of imaging, how to acquire them, what makes a good test, in order to be able to figure out for each individual patient, how are we going to acquire the information, not necessarily, you know, one imaging modality versus another, and just knowing one area, but sort of knowing everything so you know what's best for each patient. All right, so let's reorient ourselves here real quickly. So this is Ptolemy's map of the world. So Claudius Ptolemy, born about 90 CE until 170 CE, was a scholar living in Alexandria, and in about 150 CE, he produced his influential Geographica, which included contributions to the field of geography, including lines of latitude and longitude, which were the first time that these appeared on maps. His maps would actually remain the most advanced for over 1,000 years. So these were not improved upon by the Romans or Byzantines, and ultimately were lost in the transition to medieval Europe, although they were maintained by Muslim scholars during this period. Ultimately, they would be rediscovered by European scholars in the mid-1400s, leading to reproductions like this one in the British Museum by Dutch engraver Johannes Schnitzer in 1482, and a copy of Ptolemy's map produced from 150 CE would actually be carried with Christopher Columbus on his initial voyage west across the Atlantic Ocean. So part two, I really don't want to cath this patient. So let's talk about evaluating for ischemia. So one of the most widespread uses of multimodality imaging is the evaluation of known or suspected coronary artery disease. It can be evaluated using things like an exercise treadmill test, coronary CT angiogram. You can do exercise or pharmacologic SPECT or PET perfusion imaging. You can do stress MRI or exercise or pharmacologic echocardiography. You know, really the world is your oyster when you want to evaluate a patient for ischemia. And in one of these multimodality imaging reviews, I thought they put together a great table on the different ways in which we can evaluate ischemia, some of the strengths and limitations of each of these individual studies. But I think the most important thing they did was sort of look at the data and gather together the sensitivity and specificity for each one of these modalities. And what you'll see is that the most sensitive, sort of by a pretty significant margin, is coronary CTA, while the most specific by a decent margin is cardiac PET. So let's talk about radiation. You know, radiation is something that as cardiologists, we can be a little bit cavalier about. You know, in training, all of us spend time in the cath lab and you get your radiation badges every month. But routinely, you know, and if you look at the data for the radiation information that's collected from different radiology departments and IR and especially interventional cardiology always has the highest numbers sort of across the board when you look at the numbers nationwide. And if you talk to radiologists, they think that this is sort of a reflection that the radiology side of things takes radiation a little bit more seriously. And a lot of us do take it fairly seriously, but maybe not as much as other specialties, and definitely not as much as patients, all right? So even if this isn't something that you think about when you're ordering tests for patients, this is something that patients are always thinking about. And this is one of the difficulties getting cardiac CT off the ground, you know, 15 years or so ago when they were trying to do it, is there were all these reports about how much radiation it was going to give patients. And there was a lot of pushback from patients and patient advocacy groups about using these tests. So you do need to know a little bit about radiation, because I can tell you, you know, especially in the CT suite, we are frequently getting questions from patients before they go in the scanner about what sort of radiation they're going to get. So one study you should know is the BEER-7 study, which estimates the average risk of developing cancer for the US population to be approximately 1% per 100 millisieverts of radiation above background. And so average background radiation in the US at sea level is about 3 millisieverts a year. So how much radiation are we giving patients with these tests? So the worst offender is the dual isotope MPI, which will get you somewhere between 25 and 30 millisieverts. What's known as a retrospective CTA, which is what we usually use for our structural studies, which gathers a full cardiac cycle, averages about 18 millisieverts. A PET is going to net you about 13. SPECT is going to be a little bit less at 11. Your standard diagnostic left heart cath with a left ventriculogram is going to be anywhere from 6 to 8. Prospective CTAs, which is what we use for coronary CTA, and we're trying to just get a sort of quick snapshot of the heart, can net anywhere from 1 to 7 millisieverts, but on average about 3 to 4. And coronary artery calcium, which we think is our sort of least radiating test, is still going to get you 2 millisieverts, which is almost as much as your sort of normal background radiation in a given year in the US. There's this concept called ALARA, or as low as reasonably achievable, which says that we need to be trying to achieve whatever imaging we can in these patients using as little radiation as possible. So case number 1, we have a 74-year-old female with a past history of peripheral arterial disease and a 60-pack year smoking history. She's coming in with shortness of breath and dyspnea on exertion times 1 week. She's usually very functional. She stays at home and takes care of her mother, but she's gradually been getting short of breath with walking requiring rest. Also noticed some bilateral lower extremity swelling. On presentation, some notable numbers. Her blood pressure is reportedly 205 over 188. I do not know how much I believe that number, but it's what they had documented. And her creatinine is 2.34, right? So when we think about which imaging modalities we want to look at, we're looking at renal function. We want to try and avoid something with contrast. And with a blood pressure that high, you know, maybe a dobutamine stress echo is not the best thing for her right now. So we look at her initial EKG, nothing too special here, no acute ischemic EKG changes that say that we need to send her straight to the cath lab or anything else like that. And so we decide to pursue a PET nuclear stress test. And so here we have our kind of individual slices and the axial and lateral cuts. So you can see our stress images on top, rest images on the bottom. And as we scan through these, you can see her stress images. You know, it definitely seems like we've got less uptake here in sort of the infralateral wall. You know, eyeball wise, I'm looking at this and thinking, this looks like it's dilating a little bit, possibly has some TID. We look at the polar maps and sure enough, you know, we have a defect here in sort of the infralateral wall. Her TID did end up being kind of borderline positive. And so luckily for us, when we get PET scans at EUH, we actually practice hybrid imaging here every day. And that in addition to the nuclear PET scan, we also get a coronary artery calcium score with our CT. So coronary artery calcium scoring is a very, very standardized protocol, same size slice thickness, same amount of radiation, no matter what size patient you're doing it on. And what it does is it basically lets us look at calcium within the coronary artery tree. This is the raw scan data that we get, and then we put it through a processing software, which takes every pixel above a certain Hounsfield unit and turns it this pretty, I guess that's magenta or fuchsia color. And then we can use our tool set to sort of highlight the calcium in the different vascular distributions. And so for her, you know, she had calcium in her left main and her LAD and her circ and her ostial RCA. And as we scan through the image, we're highlighting all of these areas in the individual arteries. And ultimately what we end up with is this calcium score. So this patient's total calcium score was, you know, almost 1750, and we get individual calcium scores for each different vessel. So ultimately this patient, because of this abnormal PET, because of this 3-vessel coronary calcium, was sent to the cath lab and ultimately sent for triple bypass surgery. So that's hybrid imaging performed every day. So let's talk about something that we use a little bit more in the CT side of multimodality imaging, and that's kind of the interplay between a CT coronary angiogram and nuclear medicine like SPECT PET. So we have a 63-year-old female who has a past medical history of hypertension, diabetes, and obesity with a BMI of 50, who was sent to us from an outside cardiologist to the CT cardiac CT department at Midtown for evaluation of a test that she had after she came to see them for dyspnea on exertion. So her initial evaluation there included a transthoracic echo, which showed a normal EF, and a CT chest, which had no pulmonary pathology. A nuclear stress test was performed at their clinic, which showed a large 30% reversible inferior defect. Now, this is a large patient with a BMI of 50, so it was thought to be breast tissue artifact, especially given her normal EF. So, that's a type of multimodality imaging a lot of us use every day that we don't think about, right? The abnormal stress test with a normal echo, as well as atypical symptoms, but 30% reversible defect is quite large. And so they actually sent her up to us at Midtown for a coronary CTA to either confirm or refute their findings on nuclear stress test. So, Dr. Gleason and I worked together. We developed a little bit of a modified protocol for this large patient to try and get good images, and we were actually able to get really great images. And so when we do a coronary CTA, what we end up doing after the scan is processed is we end up with what's called a multiplanar reconstruction, right? So you've got 3 different planes that are all orthogonal to each other. And each one of these planes is manipulatable in the 2 other windows, and then we view it in the 3rd window, right? So we've got red, green, and blue. And then the CT processing software allows us to highlight individual coronary arteries that sort of delineates out the blood tissue interface, and then create what's called a curved multiplanar view of that, which is what this looks like, right? So now we're able to view the coronary arteries kind of laid out on their own. So this is the RCA, right? She had this inferior defect, so we wanted to evaluate her RCA. We can lay it out. These 2 images are at 90 degrees to each other, so I can make sure that I'm not missing any plaque that's been foreshortened, and I can scroll through it and look at multiple planes in the axial view here as well, in case I have any areas that look suspicious for blockage. One of the advantages of CT that we're going to talk about today is that it is far and away the most manipulatable after acquisition of all of the imaging modalities that we use. And so we can actually take this curved NPR and we can kind of spin it around and look at it in 360 degrees. And this is sort of a video that I took of it, but in real time, I'm able to take my mouse and drag through and zoom in and look at this coronary from all angles. And what we can see here is she has a totally clean RCA, and that was just artifact on PET. And this is something that, we will not frequently do, but a lot of times you have a PET scan that's a little bit abnormal. Maybe it's artifact, maybe it's not. But we want to see, is there any anatomical coronary disease that correlates to that without having to send the patient to the cath lab, or a patient like this that just can't go to the cath lab because they break the weight limit for the cath table. And the same thing for CT. Maybe we get a CT and it's got what looks like a borderline lesion on it. We can see it anatomically, but we can't tell flow from it. So we need to know, is this an obstructive lesion? Is this lesion causing symptoms? And we may send that patient for a PET scan to see if there is any perfusion abnormality in that territory. All right, so let's reorient ourselves again. And this is the Mercator projection. Probably looks a little bit more familiar to you guys than some of the other maps we've seen thus far. So Gerardus Mercator was a Flemish geographer and cartographer who produced the first edition of his famous map, which is this one in 1569. So importantly, he was able to solve this problem of translating a 3D shape onto a 2D surface, which is a problem that we run into a lot with imaging, right? These are all 3-dimensional structures that we are trying to image and evaluate in 2 dimensions. His map is considered what's called conformal, which means that it projects north is up and south is down everywhere, while also preserving local directions and shapes. And that produces some distortions in the map that get a lot of criticism, and reasonably so these days, as far as really emphasizing the northern hemisphere versus the southern hemisphere. But there's a reason that it's still the predominant map that's used today, and that is that this was a very difficult problem to solve. Mercator is the one who happened to solve it, and we still utilize his solution 450 years after the fact. Part 3, who watches the watchman? So classically, evaluation of the left atrial appendage has been the exclusive purview of 2D transesophageal echocardiography. We use TEE to evaluate for thrombus, for size of occlusion devices, and to guide intraprocedural device placement. And for the original Watchman trial, Protect AF, all pre-procedure sizing for devices, intraprocedural guidance, and post-procedure imaging was done with TEE, because that's how it's always been done. However, in the early Watchman trials, they actually used an average of 1.8 devices, so almost 2 devices per patient to achieve adequate device sealing. So this illuminates the accuracy limitations of TEE for planning for these procedures and device size. And so one group out of Henry Ford, including our own esteemed Dr. Adam Greenbaum, before he came down here to join us, wanted to look at, could we apply CT and more importantly, 3-dimensional CT to help guide Watchman implantation and especially have an impact on this early operator learning curve, right? So as you're first starting to put these devices in, you're not going to be as good at it as you're going to be later on. So can we improve our early operator device implantation? And so their hypothesis was that CT would help capture the anatomic complexity of the appendage with more accuracy than echo can provide. So anyone here who's ever done a TEE and tried to look at a decent number of appendages can tell you some are easy to see, some are quite hard. They use their experience with transcatheter valve procedures to help develop a method for device sizing and procedural planning using both 2D and 3D CT. So this is the scheme they came up with. Remember, we've got, anytime you see these colored crosshairs, we're talking about that multiplanar reconstruction. So what they do is they align one of their planes at the opening of the left atrial appendage. They then take one of their orthogonal planes to that, in this case, this green plane. And what they're going to do is they're going to line that green plane up on the longest axis of the appendage, that red plane, which is going to be at their ostium, or sort of where you're going to implant the device, is going to be centered on the left circumflex artery to make sure you're right at the opening. And then that's going to give us this sort of cross-sectional view of the opening right here, where we can measure diameters in short and long axis, as well as get an area and a perimeter around the outside to more accurately size what size device we're going to be able to fit in there. Now they went a little bit further too, and they said, well, now let's try and simulate what our delivery catheter and sheath are going to look like in the left atrial appendage. Let's use our 3D CT software to create some 3D reconstructions of the left atrial appendage. Let's throw it in a mode called inverted MIP, basically to create a virtual angiogram of that left atrial appendage and set up our C-arm angles. So we're already going to know before we even go into the cath lab what angles we're going to need to have on the C-arm as we implant this device. And they even took it a step further. And they took these 3D reconstructions of the left atrial appendage, and they used a mode that's actually included in one of our CT analysis packages, 3Mintio, and they 3D printed these appendages. And if there were any that were sort of in between size or that they had difficulty sizing, they would 3D print that appendage, and they would manually try out the different size devices in it. When I talked to Dr. Greenbaum about this, I was like, man, who thought about this? This is actually a great idea. What made you guys decide to take this extra step? As he said, he's like, well, we just kind of had a 3D printer laying around and wanted to learn how to use this part of 3Mintio and thought it would be kind of cool. So we did it. And it turned out it worked for some of these in-between sizes that they had. And so ultimately the data they got from it was really good. So their first 53 devices, they had a 100% implant success rate versus the 1.8 average devices that were required in Protect AF. They only required 1.2 devices on average. They had no procedural or device-related safety adverse events within 7 days, no serious pericardial effusions. And the most impressive part to me was this implant time. So they looked at the mean time for the first 3 patients. They were able to do it in 48 minutes versus the 82 in the Protect AF trial. So by doing this CT planning, they were able to almost cut their implant time in half, which cuts down on patient anesthesia time, radiation time, and ultimately I think reflects really well on the success of using CT to plan for these procedures. But you can't use CT in the procedure itself, so we still use TEE to implant these devices. So for this patient, we did the pre-planning with CT, and now we're in the procedure itself. The first shot that we always get in one of these procedures is at 0 degrees of the right atrium. So if you develop an effusion during a procedure, the first place it's going to show up is behind the right atrium, so we want to make sure we've got a good baseline there. We then go through and we just sort of do our own manual measurements again of the appendage to make sure that everything lines up consistently. And that the device is going to fit. One of the most important things that we do with echo guidance of these procedures is guiding the transeptal crossing. So for different procedures, you want to cross the septum in different places. For Watchman, you want to make sure that in the AP window, you are posterior. So here's our aortic valve in short axis, so anterior, posterior. We're in the posterior segment of the interatrial septum. And then you want to be mid to inferior in height. So this is our sort of a modified bicaval view, superior, inferior. So we are kind of mid-inferior crossing here. We're going to guide their wire across the left atrium into the left atrial appendage, make sure that we help guide that delivery sheath into the left atrial appendage without poking through. Now that they've got the sheath there, we are going to deploy our device. Once again, kind of one of the shortcomings of TEE is this acoustic shadowing, which blocks out kind of the moment that the device is deployed. And then once the device is deployed, we want to make sure that it's well seated in there. So we're going to go through in our standard TEE angles. Here, starting at 0 with color Doppler to make sure we don't have any significant leak. We're going to look at 0, 45, 90, and 135 degrees. No significant leak around this device. It looks like it's well sealed in place. Next, they're going to do what's called a tug test, which is exactly what it sounds like. They're just going to tug on it a little bit, make sure that it's well seated in there. We're now going to look at it in 3D TEE. So we're going to look at it in standard 3D, make sure it looks like it's seated in there well and it's not wobbling around a lot. Let's throw some color Doppler on there, make sure there's no visible leak around the device now that it's in there. And so now they've released the device. We're going to go through one more time looking without color and with color, making sure the device is well seated and there is no significant leak around it at 0, 45, 90, and 135 degrees. The last thing we're going to do as we come out is we're going to look at the interatrial septum after they have come back across our brand new iatrogenic ASD. We want to make sure that we have only got a left to right shot, which a lot of these patients with atrial fibrillation, they've got high left atrial pressures, should not be a problem. So left to right shunt here, no need to close. It should close up mostly on its own over time. And then finally, one last shot of that right atrium just to make sure that there's no effusion there. So 90 days later, so as in the original Protect AF trial, they would use TEE to look at these patients after 90 days. So this is the part that matters, right? So we're putting Watchmans in these patients because we don't want them to be on anticoagulation. And so we need to do a follow-up at 90 days to make sure that the device is well seated, there's no significant leak around the device, and there's no thrombus on the device. And if all of those things are true, this is when those patients can come off of anticoagulation. Traditionally, this was done with TEE, but also it's been something that's been studied in CT in recent years. And what they found is that CT monitoring for post-procedure is just as good as TEE. In fact, it's a little bit better at picking up on peri-device leaks. In the original Protect AF trial, they said that any leak over 5 millimeters was significant. CT is a little bit better at picking up on smaller leaks, but those are felt to be insignificant. When you get to the significant size leaks that are going to keep these patients on anticoagulation, the numbers are about the same, but you can potentially save your patient getting another TEE, which can be uncomfortable. And at this point, traditionally, this would be this patient's third TEE. And even though they were asleep for the second one during the procedure, you know, you can kind of sneak up on patients with that first TEE with gargling the lidocaine and how bad that tastes and how uncomfortable the TEE itself can be. But by this time, the patient is well aware and a lot of times are a little bit wary coming into this procedure. And so what we're going to do is we're going to look at another CT software package here through Mincio that we use for a lot of our structural CTs. Once again, we've got our multi-planar reconstruction windows here and our 3D reconstruction down here. What we're going to do is we're going to maximize that 3D construction. We're going to do a little bit of what's called sculpting, where we're going to take out different parts of the CT that we don't really want to look at, just so that we can focus in on the areas that we want to see. So right here, you know, we're taking out rib cage, sternum, things like that that are getting in our way of looking at the heart itself. You know, we can pretty quickly get rid of those things. We can carve down as much or as little as we want to make sure that we can focus on the areas that are of interest to us. What is going to show up on this CT as far as soft tissue is concerned is based on where our contrast bolus is. in the body at the time that we acquire our scan. Here we can see the patient's two bypass grafts. We're playing with the contrast width and level a little bit to drop the soft tissue in and out. So here, bypass grafts, aorta, left ventricle. Here's our appendage up here. We could see our device sitting in the left atrial appendage briefly there as we drop the contrast down. And once again, here we're just kind of surveying to make sure that our device is sitting where we want it to be and sort of looking at it in relation to other cardiac structures. Nice looking Watchman right there. And so now we're going to use our multiplanar reformatting to look at the device in a little bit more detail in the 2D imaging. So right here, I'm scrolling through the different windows. I'm going to go ahead and line my planes up on the device in the left atrial appendage. We're going to zoom in so we can take a little bit closer look at it. And I'm going to line up my red plane right here to be sort of perpendicular to my Watchman device and give me that en face view in my red window down here. All right, so now I've got my en face view. I've got 90-degree views of the device in short axis. And what I can see is the left atrium is well filled with contrast. My device itself is internally thrombosed, which is okay. That's good. That's what we want to see. But I'm also seeing a little bit of lack of contrast on the outside of the device here, which worries me a little bit. We'll take a closer look at that in just a second. Right now, what I'm going to do is I'm going to line that en face plane up along my widest axis here. I'm going to make a measurement of the diameter of my device here to look at what kind of compression I've gotten, which is my EP and structural people will know is an important factor in determining how well placed our Watchman device is. And now I'm just scrolling around here and able to look, all around the device in 360 degrees. I'm seeing that there's no significant contrast leak behind the device, no worries about peri-device leak. But once again, I'm a little bit worried about this sort of hypoattenuated area on the outside of the device right here, which likely represents thrombus on the device itself. And so now I'm going to take one more look at the device and another 3D reconstruction algorithm that we use in 3Mencio. And so here I've got my 2D images on top, my 3D images on bottom. I can see that that device is well seated in the left atrium. It's internally thrombosed. I'm not getting any contrast extravasation distal to the device, but boy, I can see this clot kind of just hugging the outside of the device out here and can see it really well right there. If we look at the data, we know that anywhere from about 10 to 15% of patients will have thrombus on their device in some way, shape, or form post-procedurally. And unfortunately for this patient, it's going to keep them on anticoagulation for a little bit longer, but keep them on anticoagulation for another 4 to 6 weeks, come back, scan them again, or we could do a TEE this time. And if the thrombus is resolved, then we can think about taking this patient off of anticoagulation. All right, let's reorient ourselves here real quick. So this is Google Earth, which started as Keyhole software in the 1990s. It was a yearly subscription service that you could get, and they used data from USGS satellites, Landsat 7 and Landsat 8, to produce really a zoomable map of the entire globe. So it was this digital globe. You could zoom in pretty far in a lot of different places. Ultimately, Google would acquire this in 2003 and make it free to everybody. I still remember the first time I heard about it and downloaded it was, just thought it was the coolest thing I'd ever seen. I could start in space and zoom down and look at my backyard on satellite imaging. And, this really represented something where you could get a pretty accurate map of anywhere in the world. But, it's 2003, 2004. If you want to actually get somewhere, you still got to go to MapQuest, type it in and print off those directions to take with you. So it's gives a lot of structural information, but not necessarily a lot of useful information just yet. So part 4, fixing a hole where the rain gets in. Let's talk about paravalvular leak. All right, so paravalvular leak, or PVL, is a common complication associated with surgical and transcatheter procedures. It occurs in between 2 and 18% of all surgical valve replacements. And overall incidence is higher among patients who undergo mitral valve replacement compared to the aortic valve. So your incidence is higher with mechanical valves, so about 8% versus bioprosthetic valves, 2% in the aortic position, and a little bit higher with mitral valves, so about 17% for mechanical mitral valves, about 7% for bioprosthetic mitral valves. Although 75% of PVL is diagnosed within the first year after surgery, if you look at the Kaplan-Meier curve for PVL and mitral valve replacement, you'll see that your PVL-free rates are 96% at 10 years, and then drop to 86, almost 87% at 20 years, which shows us that this process continues to occur over time. So something we need to be watching out for in our patients with valve replacements. Risk factors for early PVL include mechanical versus bioprosthetic valves, as we just talked about, supraannular versus annular placement, your suturing technique, so is it continuous or interrupted? Dr. Guyton was actually telling us a couple weeks ago that Dr. Chin, whenever he does some of his certain type of aortic valve, he will place and individually tie 40 interrupted sutures around the annulus when he puts that valve in. This is also affected by a history of endocarditis, extensive annular calcification. Dr. Clements loves to talk about that hostile mitral annulus with a ton of MAC, as well as tissue friability. The main signs and symptoms of significant PVL are classic shortness of breath, unexplained heart failure, and then things like hemolysis and symptomatic anemia. So on the structural service, whenever we're admitting a patient with even mild PVL, one of the first things we'll check is a hemoglobin and an LDH, as well as left ventricular enlargement in aortic valves and left atrial enlargement with mitral valves. And here, imaging is the key in identifying if this is paravalvular or valvular regurgitation. So acoustic shadowing in prosthetic valves, as anyone who's ever looked at an echo on a prosthetic valve knows, is really going to limit your visualization. And 3D TEE is considered the gold standard for evaluation of PVL, but cardiac CT has really improved the options available in recent years. Percutaneous management of PVL is actually considered first-line therapy in most patients and centers, with surgical management being reserved for patients that are going for CABG or another valve surgery, have active endocarditis, large prosthesis dehiscence. We usually talk about greater than 1/3 of the annular circumference, or were not successfully percutaneously closed. And this is a decision tree that's proposed by a group that really looked into this. And as you'll see, basically, if they have symptomatic PVL, if it's aortic and surgical, you're going to do transcatheter approach. If it's a TAVR, you can think about balloon post dilation versus maybe another valve in valve surgery or procedure, but really for most of them looking at a PVL closure. Same thing for the mitral valves. So let's talk about our first case here. We have a 60-year-old male with a past medical history of heart failure. EF is 30%. HCM VT status post ICD. He's got atrial fibrillation on Coumadin, CKD3, coronary disease status post PCI, severe TR status post to surgical tricuspid repair, and severe MR status post to surgical mitral valve replacement with a 33 millimeter onyx valve in 2019. It's been complicated by severe PVL. His post-op TEE from November of 2019 reported that by 3D echo, there are 4 small jets seen in color Doppler, extending from about 8 o'clock to 11 o'clock that overall appear at least moderate. Patient on follow-up reports that he briefly felt better after his surgery, but about 6 months later, he's now back to severe DOE to the point that he can barely climb a flight of stairs. And so our plan is to get a structural CTA and then proceed with a transcatheter PVL closure as he's high risk for a reduced sternotomy. So once again, this is that 3Mencio software here. We're looking centered around the mitral valve. One of the things I'm really going to push in this talk today too is that, CT, in my opinion, and I think the opinion of a lot of our CT imagers is superior to valve cine. We get great views of the valve and are able to, manipulate it and look at it in real time. When we're evaluating for PVL, what we're really looking for is as we circle around, we're trying to find an area around the annulus where we don't see contact between the annulus and the valve. And so sort of going back to the beginning here, as we spin through, I'm seeing this all the way around. It really looks like this valve is just floating in free air and is some sort of magical valve that doesn't have to be attached anywhere. And the reason for that is because this is an onyx valve. And so in onyx valves, they have a radiolucent outer ring or cuff that you cannot really see on CT. And that's this cuff right here. And so our plan is to proceed with TEE planning at the time of the procedure. So basically we'll sedate the patient, anesthesia will intubate them, and we will drop our TEE probe and take a look at things before our operators come in and start. And so here we're starting at 0 degrees, 4-chamber view. And as you can see, this mechanical valve is really shadowing out a lot. It seems like we're not going to be able to see much. But once we turn on color, we see this really large jet of PVL on the lateral annulus of the valve. My probe, I'm pushing it in and out at 0 degrees, trying to find the best window for that PVL. Here I'm going to do what's called X-planing through that. So looking at a 90-degree view of that, and I see multiple jets of PVL coming through in sort of a crown shape here. I'm going to go ahead and go up to 90 degrees on my probe and counter over to that lateral surface. And here it's just PVL as far as the eye can see. So I'm going to look at it in standard 3D. Can't really see a lot as far as PVL is concerned in standard 3D. So let's throw some color on it. And here we can see what look like multiple jets of indeterminate size around that 8 o'clock to 11 o'clock, maybe 11:30 position that was described. And then another jet over here, sort of between 2 and 3 o'clock. There is another way of 3D echo that we can look at, something that's known as transillumination, or in the Philips package software, it's called TrueView, which is an algorithm of looking at 3D where I can adjust my light source to different areas around the valve, and then also control the depth of that light source as well. Oftentimes we'll use it to evaluate PVL, where I will drop my light source into the left ventricle so that it's shining up through that annulus and can see certain areas, a lot of times of subtle lucency around here where the PVL is. In this one, it didn't matter as much because there is nothing subtle about this. We can actually do multiplanar reconstruction within 3D TEE as well. So here I'm setting up my blue plane as my en face plane to where the PVL is. I'm lining up this green plane along the line on the lateral annulus, and then my red plane through one specific PVL lesion. And what we see here in that en face is that we've got multiple jets of PVL that appear to be coming in between the suture lines. And we counted 1, 2, 3, 4, 5 PVL jets here. And we're actually able to measure them for the operators to let them know what size plugs they were going to need to use. So we've got 5 paravalvular leaks that we've got to plug. So let's help our operators get in there and do what they need to do. So in 3D, we've done our transeptal crossing. And right now we've got a catheter and then a wire trying to poke around and find that first PVL. We're going to show them right where it is on color Doppler, and they're going to be able to drop that catheter right down in there. So that's hole number 1, a little bit more color, hole number 2, show them where the next one is, hole number 3. Once again, we're starting to get crowded in there, hole number 4. And so at this point in time, it can be pretty difficult for the operators to maneuver in there to see spatially exactly where they need to be, which is where the strength of 3D echo comes in. We're looking at the color around all those areas, trying to find that last hole for them. We're using our transillumination to create more depth perception to give them a little bit more spatial resolution within the valve itself, changing that light source around to help our depth perception as they're trying to manipulate that wire into the last hole. And here they come. And now we've got wires in each of our paravalvular leaks, and we're just going to start dropping plugs in them. So the plug's going to go down, number 1, number 2. I can see as we're dropping these plugs that we're getting good sealing here with no residual leak. Plug number 3 goes in, leak looks better. Plug number 4, leak looks even better. Plug number 5, we've still got a little bit more leak here. So they're actually going to take that one out and try it for another plug there. Now I've got my 5th plug in on this side, minimal residual leak. Everything's looking good, except now my hole over here is starting to leak a little bit more. And so you can really see how well these 5 plugs are lined up over here with minimal residual leak. I'm looking at my valve leaflets to make sure that they're still moving well, using my transillumination to make sure that all my plugs are well seated and not moving around. And now we're going to come after this last plug over here. We've sealed it, minimal residual PVL. Our valve leaflets are moving well. We're getting some awesome pictures showing how flush these plugs are, how well stabilized they are, and how well our valve leaflets are moving. So post-procedure, access was gained at 12:37, and the sterile dressing was applied at 4:22, so skin to skin in less than 4 hours. Patient tolerated the procedure well, spends 1 night in the CCU, and then is transferred to the floor, undergoes about 30 pounds worth of diuresis before discharge home. At 1 month follow-up, he's feeling much better, notices significant improvement in his functional status, no residual PVL by TTE. It is follow-up with a mean mitral gradient of 4. So I want to talk about one more case here, and it's sort of the most complex one we have. So we have a 26-year-old male, no real past medical history, began to develop severe dyspnea at work. Within 1 month, he can no longer walk more than 40 feet, comes into an outside hospital where he's found to have severe AI, new onset heart failure with an EF of 30% and a severely dilated LV. He's transferred to Midtown where he undergoes a surgical aortic valve replacement with a 22 millimeter St. Jude mechanical bileaflet valve. Tolerates his initial surgery well, but follow-up echo prior to DC shows an abnormally functioning mechanical aortic valve and concern for possible valve thrombosis. So as you can see, LV's dilated, not squeezing great. Here's our prosthetic valve. And sure enough, seeing blood moving in the wrong direction on color Doppler here, in short axis, I can't really tell, is this blood coming through the valve itself? Is it coming around the valve? And here in the 5 chamber, still we can't tell. We just know that it's moving in the wrong direction. And so he undergoes valve sine, which shows what they say is a normally functioning mechanical AVR. We know from the echo that it is not normally functioning. So the surgical team, in consultation with our structural heart imaging team, decided to pursue a structural CTA. So once again, remember, this is our 3D reconstruction in our MPR windows. Here, we're going to pull up our 3D model of the heart. We're going to sculpt it down a little bit. Play with our contrast so that we're dropping out all of our soft tissue and we're only showing our valve and bone here. I'm going to sculpt out some of that bone so that we can look at our valve more in isolation. Oh, we want the other side. Perfect. All right. And so now I'm going to play with my contrast a little bit more. I'm going to line up my shot well, and then we're going to go ahead and cine. So here we have our very own valve cine on CT. As we're doing it, I can move the valve around, I can zoom in, I can zoom out, I can look at it however I want, and I'll give it to him. Looking at this right here, it's got a little bit of artifact that we could play with some more to get rid of, but overall it looks like a pretty normally functioning surgical bileaflet aortic valve. But the benefit of CT is that now we can go and look at it in MPR and get a little bit better look at this valve itself. So I'm going to play with my contrast a little bit. I'm going to scroll through my windows, find the right area that I want to go to, and then start lining up my multiplanar reconstruction. Once again, I'm kind of partial to using my red window as my en-face window. Then I'm going to line up my blue and green planes at 90-degree angles orthogonal to each other. I'm going to zoom in to take a good look at it, and then we are going to cine again. And here, I still am not getting great differentiation between the valve and the contrast plane, but, once again, CT is super manipulatable after we acquire the images. So we just adjust our contrast a little bit and boom, we're getting great, really clear pictures of this. And what I can see here is that there's asynchrony between these 2 leaflets that was not picked up on valve cine in the cath lab and also was not picked up on our 3D valve cine here. And now I'm going to line my crosshairs up in the middle and I'm just going to scroll around in 360 degrees. I'm going to forget to cancel out my idle timer as I do my screenshot recording, not realizing that it's going to pop up on this. And then we're going to just focus on one part of the annulus as we scroll around, looking for contrast extravasation through the annulus. Not seeing it, not seeing it, not seeing it. And then we start to get over in this area. And I'm starting to see some contrast maybe coming through, and boom, this area right here is where I'm seeing a track of contrast coming around the annulus. So I can see that, yes, this is paravalvular leak coming in right here around our aortic valve. So the decision is made to take this patient back to the OR for explant and a new valve due to his young age and fresh sternotomy. They replace it with a 25 millimeter Onyx. He tolerates it well, is discharged home 1 week later. But 1 month post-discharge, he presents back to the outside hospital with acute decompensated heart failure. His INR is 11. He's got elevated LFTs. His lactate is 9. The transthoracic there reportedly shows AI, so he started on dobutamine and transferred to the SICU at Midtown. And on arrival, he's in cardiogenic shock. Our structural imaging team is called for a stat bedside TEE to assess his valve. And so Dr. Gleason and I rushed down there with anesthesia at the bedside. We dropped the probe, and sure enough, we can see significant paravalvular leak again around this aortic valve. I don't have to go through it in too much detail. It's pretty obvious that this guy's new valve is leaking as well. And we can see large areas of leak in the short axis here, especially around the right and non-cusps. And so over the next day, this guy's maps drop into the 40s. He started on multiple vasopressors. They put in a SWAN and his cardiac index is 1.1. So the next night he's transferred to EUH and crashed onto VA ECMO with plans for kind of an urgent emergent transcatheter PVL closure. So we drop our probe in the cath lab at EUH and we can see this is left atrium, right atrium with ECMO catheters in the right atrium. It's extremely decompressed. I'm going to kind of speed through some of these images. It's not really important specifically what we're doing, but we can see he does have one jet that's going into the right ventricle, sort of right around the area of the tricuspid valve. And so as we go through here, we're helping to guide our operators to sort of wire these individual leaks. We're looking in 2D, we're looking in 3D, we're looking with and without color. And as we're guiding them through each of these, then we're starting to deploy plugs. And we're, this is complex anatomy that you can't really see on angios. So they're going a lot by what we're having to show them on echo. Spent probably 7 straight hours looking at this patient's aortic annulus. I doubt I will ever know an aortic valve better than this one. And so we're going through, we're wiring these holes, we're starting to plug them, we're following the wires and catheters through, making sure everything's in the right place. Now we're starting to deploy some of those plugs. And during this time, when you are holding the echo probe, you're right next to anesthesia, you get to know these guys really well. And this whole time, they're continuing to get suction alarms on the ECMO. They're having to pour albumin into him at a pretty continuous rate. I think they end up putting 10 bottles of albumin in him during this procedure. And we see it all coming out the ET tube. So, sort of continuous stream of edema that's having to be sucked out of the ET tube. So we turn our TEE probe around and look at his lungs, and you can see just huge amounts of fluid, very little flow through the lungs themselves. So we continue, we're going, the guy's sick, pressure requirements are going up and up. They're continuing to get suction alarms on the ECMO. We're placing more and more plugs. We're trying to chase all of these different leaks. These guys, the operators, Dr. Bob Lieros, was doing a great job in there. These are not easy holes to hit. And you're talking about being in there for 6 or 7 hours focusing on something like this. And eventually what we start to see is this, which is just sort of diffuse leak all around the valve, kind of all around where the suture lines are here. And what that means is that this valve is actually starting to dehiss. The tissue is extremely friable, your suture lines are starting to come loose, and at that point it's time to stop. But the patient is even more unstable now than he was when we started, continuing to get suction alarms. So luckily, Dr. Kim, one of our pediatric interventionalists, was in there and said, hey, you know what we do in kids when we can't put a balloon pump in? We just do a septostomy and sort of allow left to right shunting of blood. Maybe we should try something like that. We've looked at the lungs, we've looked at the left side of the heart, which is pretty dilated and stagnant at this point. We say, you know what, let's try something. And so once again, we help guide them across the septum here. Right atrium, left atrium. Here's their transeptal catheter going across. We pass through with the wire. We thread that wire with a balloon, and then they start to inflate this balloon, which is quite large. So we're watching the balloon inflate here. I believe it was a 34 millimeter balloon. Boom, it's up. We've done our balloon septostomy. We're looking at it in 2 different planes to make sure that we're getting a large opening in the hull of the septum there. And as soon as they deflate it, the strongest, fastest, most robust left to right shunt I've ever seen in my life. All of a sudden, the right atrium fills up, the suction alarm stopped going off, and the patient's systolic blood pressure jumps up to 160 from the 80s because now we're finally able to get enough blood flow to the ECMO to maintain perfusion. And this is our final view of the valve right here. As you can see, just massive residual leak, but our right atrium looks good and our ECMO catheters are getting plenty of flow to them. So for this patient, immediately after the septostomy, like we said, his blood pressure shoots through the roof and comes off almost all vasopressors. He returns to the 5E ICU and has an expedited workup for transplant initiated shortly thereafter. They were unable to stabilize him enough for listing, so he actually goes for BIVAD. Unfortunately, ultimately develops an MDR Klebsiella infection and passes away a couple of weeks later. So the last map I want to talk about is Waze. I'm sure a lot of you guys have this app on your phone, and sort of thinking back to that original clay tablet with the map of Mesopotamia. These days, you've got a computer in your pocket, you press one button and it has maps of every road system in the world. It'll tell you exactly how to get to where you need to go. It'll change your routes mid-route to show you the fastest current way to get there based on GPS data. Heck, it'll even show you where Cops in the nearest Waffle House is. And so this is really kind of the epitome anatomy of not just great structure, but great functional imaging as well, that I think a lot of us take for granted today that we wouldn't have dreamed possible even, 10 years ago now. So part 5, I just want to wrap up quickly talking about the future of multimodality imaging. So we've discussed several complex problems today that are solved by using multiple imaging modalities to view the problem from different directions. We've combined anatomical and perfusion data to evaluate coronary disease. We've combined the more precise measurements available with cardiac CT with the data, live data and color flow provided by TEE for Watchman planning and implantation. We've used CT to solve the problem of device shadowing in order to establish anatomic detail, combined with 3D TEE and NPR to improve spatial maneuvering in complex structural cases. Like these PVL closures, but are there ways in which we can tackle these issues with less cost to the patient? When I say cost, I mean not just money, but time, radiation, contrast, sedation, and overall risk. The answer is yes. So the future of coronary imaging is already here, right? So CT-FFR, this is, gives us both anatomic and flow data telling us which lesions are significant. Unfortunately, it's a pretty limited capability right now. It's kind of owned by HeartFlow. You have to send your images off to them. They run it through their giant black box supercomputer and then send this back to you. So it's not very timely and can be very expensive to patients, but hopefully as this gets cheaper and quicker, then that will solve this issue of having to look at patients with sort of anatomical and perfusion imaging separately. What about the future of appendage imaging? Well, it's rolling out right now. So TrueView Glass, which is an update on that transillumination view, is a new 3D TEE imaging algorithm from Philips that delineates a clear blood tissue interface. Where it really shines in their initial publications is left atrial appendage structure. So it basically cuts out everything but the blood tissue interface. And as you can imagine, if we can get pictures like these, we can make really accurate size measurements with TEE instead of having to do CT as well, potentially. How about the future of complex structural anatomy? So sort of the latest, greatest thing in multimodality imaging is virtual reality imaging. I really wanted to show some of these videos, but my talk is already running late and I had to cut them out. If you get a chance, take a look at this paper from JACE that was published pre-pub in October, came out last month online. They've got a lot of videos of these new virtual reality integrated echo and CT models of hearts that Roberto Lang and his group up at University of Chicago have been making that are really mind-blowing. If you were in the echo lab either at Clifton or Midtown around the time that this paper came out, you probably had me coming up to distract you from whatever actual important work you were doing to show you these super cool videos that are in the supplemental materials of this paper. So these are my references for the talk. I really want to take a moment and give thanks to a group of people that have been really important to me this year. So first and foremost, Dr. Clements. He's the one who gave me the opportunity and the guidance to be able to spend the last 6 months studying multimodality imaging and has been sort of my echo guru over the last year. Of course, our whole structural imaging team over at Midtown, so Dr. Gleason, Dr. Sia, Dr. Shekaladze, these guys have really taken my ability to do echo and CT imaging to a whole new level. The structural heart team as a whole for just putting up, having me around for the last 6 months. So Dr. Bablieros, Dr. Greenbaum, Dr. Devreddy, and Dr. Guyton, who supervised me in structural clinic. I want to give a special shout out to Derek Lemon, who's our CT tech at Midtown and did a lot of the work with us over there, teaching me about the fundamentals of CT, all of our echo techs and staff, Cindy and Sharon over here at Clifton for putting up with me for, probably 7 or 8 months out of the last year. And of course, Dr. Williams for giving me the opportunity to be here in the first place. I hope you guys enjoyed it. We're cutting it right at 60 minutes. And so with that, I will take questions.
John, thank you for a wonderful talk and a real tour de force review of anatomy and integrating 3Mensio and all those awesome images you're able to integrate. I was going to say, for the sake of time, almost everyone watching this talk knows John probably has his cell phone. I figured you're welcome to call him if there's any like urgent pressing questions. I'll open it up to the group for a quick question for John, but I was going to hold mine and just catch him next time I saw him in the echo lab.
I think that's fair. I'd hate to hold anybody too late this morning.
But thank you, John. That was really excellent. I'm glad your dad got to tune in and watch that this morning. A fantastic talk, and we appreciate all your hard work.
All right. Thanks so much. I appreciate it.
The preceding program is copyrighted by Emory University.